we're switching tack a little bit now from fast-moving consumer goods over to healthcare.
But
Before, we'll check in with Adrien.
So, Adrien, still in good shape after 6 hours of drawing and
Yes.
it seems.
Keep them coming.
And you are still happy with your first for the inspiration and from our guest?
I wish I had more space and more time to capture everything. That session was full of ideas. So.
Great. Well, we look forward to it. As we mentioned to anyone who's registered, we will be sending out the sketch notes after the fact, and they'll be aligned with the videos that correspond to each session. So, are we ready?
Yeah, I am. But I am not maybe the most important. Now we are going to switch from the FMCG world, which is close to my heart, to the healthcare sector, which is also close to my heart. So we will have now a pre-recorded roundtable because one of our guests is based in West Coast in the US, so quite early. Now the topic is fantastic, improving Black maternal health equity with a behavioral science-based app for doctors. So we will have Brianna Esch, who is MD and Medical Strategy Director at Wonderman Thompson Health, and my colleague Suzanne Kirkendall, who is the CEO of BVA Nudge Consulting North America.
So this session with Brianna and Suzanne will be moderated by Marie El-Ayani, who's the Client Director in BVA Excite's Healthcare Division here in Paris. So take it away.
Hi everybody, my name is Marie El-Ayani. I work at BVA in the BVA Excite in the health department, and I'm delighted to be moderating this roundtable today on an issue that is very dear to me as a woman, as a mother, and as a mother of biracial children. So the subject here is improving Black maternal health equity with a behavioral science-based app for doctors. So welcome to Suzanne, a member of BVA Nudge Consulting, and Brianna, lead strategist at Wonderman Thompson Health and the Health for Equity initiative. So Suzanne, your specialty is to create effective interventions to help people live a healthier life using your combined expertise in psychology, public health, and also in behavioral economics. So you have recently worked with Brianna on the subject I've just introduced, and I know that you have had a busy summer on the subject. So I let you present yourself in more detail before asking you a few questions.
Thanks, Marie. We're very excited to be able to share this case study with all of you. As Marie mentioned, I'm Suzanne Kirkendall. I'm CEO of North America at BVA Nudge Consulting. My background is in public health and health behavior change and health communication. So this work has also been very close to my heart and has been really a delight to partner with Bree and the whole Wonderman Thompson team on. So I'm very excited to share this with you all. Before we get into it, I'll let Bree introduce herself as well.
Hi, everyone, and thank you so much. It is such an honor to present today with my partner here, Suzanne, who we've met a couple years ago and have been working on this initiative that we are so proud of. So it's truly an honor. Thank you to the Human Advantage Conference for inviting us to speak on this, and it's a pleasure to be here. My name is Brianna Hecht. As you heard Suzanne, everyone calls me Bree. So if I meet you in the future, feel free to call me Bree. It is just wonderful to be here. My background is also in public health. That is how Suzanne and I first bonded, I was trained in both medicine and public health at SUNY Downstate in Brooklyn. I then went into a career consulting in the film industry before finding myself in healthcare communications and advertising, where I am today. And it has been an honor and a privilege to help lead the Health for Equity practice, which is a health equity center of excellence that was founded at our healthcare communications agency, Wonderman, Thompson. As we go into the next slide, I can describe a little bit more about what we do. Great. So we were actually established in 2020, and then we were awarded funding by the WPP Racial Equity Grant in 2021 for us to build the infrastructure of our practice and address particular topics in areas of health inequities over the subsequent 3 years. We are about to enter into year 3 of our grant. And our mission and goal is to drive change and solutions towards addressing health inequities in various disease states and really discovering the root causes of these health inequities and how we can best address them. So through that, we are always looking into data-driven, strategic, and culturally competent ways to address health inequities across various spaces. And because of that ethos, we were thrilled to meet Suzanne and the BVA Nudge team with their experience in behavioral science and really being able to address the root causes and the most effective ways to drive change across various challenges. This has been an incredibly fruitful partnership, and we're looking forward to sharing this case study with you. Health for Equity works in a 4-step process where we diagnose, prescribe, treat, and prevent health inequities. And through this process of intervention mapping, we're actually able to really explore all 4 of these phases. And so we're excited today to share some aspects of the intervention mapping process through which we are addressing, in this case, Black maternal health inequities.
Thank you. So can you tell us a little more about how this project came about?
Absolutely. So the Black maternal health crisis is one that we knew immediately as we were preparing for our grant submission and wanting to prioritize various inequities that the Black maternal health crisis, which is not only in the US, but is global, that this was very much a priority for our team and has been a passion area for many of us involved in this project. With these appalling statistics that I'm sharing here, while we recognize that the crisis is indeed global, for the intervention mapping process and for what we are designing and speaking about today, we did focus on the cohort in the United States. So these statistics reflect that. So Black women in the US are up to 3 to 4 times more likely to die in childbirth nationwide in the US. New York City, which is close to our heart as Wonderman Thompson Health, one of our city locations is Manhattan. Unfortunately, the statistic is outrageous. Black women in New York City are actually 8 to 12 times more likely to die in childbirth and 12 times more likely to die from complications. While these are appalling and egregious, what gives us some hope and what drives our motivation to find interventions that will work to help address the health inequities that are causing these awful statistics is that, in fact, evidence shows that 60% of what occurs is actually preventable. So in working with Suzanne and team and discovering what those are, we do find hope in hoping to be part of the solution in some of these cases.
Thanks, Bree, for giving that really important background. So, you've mentioned a couple times this concept of intervention mapping. And this is the behavioral science approach that we've taken throughout this entire project to make sure that any solution that we develop is very rigorous and science-based, so it has the best chance of being helpful. So what I'm going to do on the next couple of slides is explain intervention mapping, its logic, and the process, so that you can all see what has gone into the efforts so far and where we're going from here. So first things first is the conceptual framework of intervention mapping is something called the social ecological model, or the SEM. And it looks like a little onion or a little eyeball here on the bottom left, because it's essentially a way of thinking that makes us look beyond the individual with the health problem, in this case, Black mothers, and remember that we as humans live in a large and complicated and multi-layered context, and that our context has a strong influence on us, good, bad, and neutral. And so it helps us to break down that context in an organized way so we can identify all of the factors that impact health, not just the things at the individual level. Because otherwise, what we often do is we just think about the individual and we forget about all the other ways that our health can be affected. So I'm going to break down what these layers are. The first layer is, of course, the individual with the health problem. The factors that we look at on this level are everything from biology to your personal history, any knowledge, attitudes, skills, and beliefs that you have that are relevant to the health problem. And if you don't take a social ecological model approach to health behavior change and health interventions, you usually stop here because this is what's intuitive and obvious to most of us. And this is not sufficient because, again, we don't live in a vacuum. We're very influenced by the world around us. So let's see what those other levels are. The second layer of the social ecological model is the interpersonal layer. So these are all the relationships between the patient or the person with the health challenge and those in their life. So that could be healthcare providers, HCPs, that could be partners, family, friends. That can also look at the relationship between one healthcare provider and another. For example, in the case of a pregnant woman, she might have her gynecologist and she also might have her general practitioner. And those two might need to coordinate, or another specialist if she has other comorbid conditions. And so looking at the relationships around the person is very important to see what's going on with their health challenge. The next layer above that is the organizational layer. And this is where the structure of things like the doctor's office or your workplace or other organizations start to be illuminated. So it's the methods or the tools or any other ability to access care that impacts the patient. So for example, what are the processes that are required to sign up as a new patient at the doctor's office, to make an appointment, to pay? What is your workplace's maternity leave or sick leave policy? These sorts of things within an organization also have an impact on your health. The fourth layer is the community. So these are schools, workplaces, neighborhoods, places where you spend time and kind of absorb, but it's not one individual or one specific thing about it. And it's really important here to acknowledge social norms. So what are the social norms of your neighborhood, of your cultural background that influence your belief around health, your belief around accessing healthcare, around daily lifestyle habits? All of these things also have an impact on health outcomes. And then the last layer, the highest up, is the society and policy layer. So this is where things like distribution of income across an entire society, the power dynamics, legal policies at a very high level start to show really important influence much beyond the individual, but really impact the individual's day-to-day and really important health outcomes here. So when we talk about intervention mapping, We use the social ecological model framework as the overall structure for how we start to look into designing an intervention effectively. Because an effective intervention, as I mentioned, does not just tackle the individual level, because that's not sufficient. People don't live in a vacuum. All of these other layers also have a strong influence on your health outcomes. And so when we first try to figure out what's causing the problem, and then second, try to design an intervention to solve the problem, we need to look at multiple levels. So it's not going to be the case very often that anyone is designing an intervention that covers all 5 levels, because that's a lot, but you should always do at least 2 if you can. So that's the overall structure of intervention mapping. Now I'm going to talk through the logic of intervention mapping itself. And you can essentially think about it like a pyramid or like building steps, but we start at the top and dive deeper going downwards. So when we're thinking about designing anything with intervention mapping, we start at the top with the major behaviors that we need to change health outcomes. So that could be doctors interact with patients respectfully. That's a behavior, but it's not very specific, right? And so this is something where it's a good starting point, but we need to drill deeper. And so when we're talking about intervention mapping, this top layer, the term that we use with this framework is called behavioral objectives. So it's the overall behavior that we need to happen, whether it's on the individual level, the interpersonal level, the organizational, the community, or the society. You identify behavioral objectives at all of these levels for the relevant target audience. Once you've identified a specific behavioral objective, or objectives, it's always more than one, you then break down that big behavior into bite-sized, smaller sub-behaviors. So you start to get more specific and more concrete about what goes into each of those larger important behaviors. And you do this again on all of those 5 levels of the social ecological model. So you can see this starts to get quite large quite quickly, and that's part of the rigor of this approach. Once you've identified those bite-sized sub-behaviors, we then break those further into, okay, what knowledge is required to complete that behavior? What attitudes, what skills, what beliefs make it possible for that smaller behavior to happen? And we call those bite-sized knowledge, attitudes, skills, and beliefs the performance objectives. And so the logic of intervention mapping is that when you have done a behavioral science intervention to increase knowledge, for example, of a bite-sized sub-behavior, that will make sure that that small behavior happens. And if that small behavior happens, then by definition, that bigger behavior is going to happen. So we start at the top and go down when we're diagnosing the problem. And then when we're creating the solution, we start at the bottom and it works its way up naturally because of the logic of this model. So that's the logic on 2 levels. We have the big structural logic of the social ecological model of the different actors and levels we need to look at. We then have the pyramid structure of intervention mapping itself and the logic of how we start to design the intervention and what we're trying to think about when we're making the intervention tools. Now I'm going to explain the process of how we actually go through this type of work. It's a 6-step process. It's very, very rigorous. When I explain it to people, I tell them, when I did my Master's of Public Health at Columbia, my master's thesis was doing intervention mapping for a year. So this is very rigorous, very involved, and it leads to really, really strong, solid, thorough behavioral interventions. So we were really thrilled when Bree and the entire Wonderman Thompson team was willing to go there with us, because I think we're creating something that's really going to make a great difference as a result. So let's talk through these steps. Step 1 is problem identification. So this is where we do a lot of literature review. So we go through all the academic papers that we can find to identify those things that I showed you on that pyramid slide or those 3-step slides just before this. Meaning we identify what are those large behaviors, the behavioral objectives at the top of the pyramid for individuals, for interpersonal relationships, in this case, like their doctors, like their partners, like their family members. What are the behavioral objectives for the organizations and for this community and for the society? Once we identify all the behavioral objectives on each of those 5 levels, that top big behavior, we continue this literature review to say, okay, for each of those behaviors we've identified as important for this health outcome, what are the smaller behaviors that make up those big behaviors for all 5 levels? And then we continue the literature review and say, okay, for each of those smaller behaviors that we identified, what are the knowledge, attitudes, skills, beliefs, other contributing factors that play into the smaller behaviors? And so every single bit of information is entirely evidence-based. It's all backed up by academic research. So we know that anything that comes out of this is going to be evidence-based and a rigorous approach. So that's the problem identification. And part of the logic here is we start with thinking about what's wrong that's contributing to Black maternal health disparities. And that's what the literature review is. We then flip it to positive and say, okay, if this is the problem, then if the opposite happens, the problem won't happen, if that makes sense. So we take it and we flip it to positive, and those become step 2, our program outcomes and objectives. And that's where we start to think about what can we do rather than what don't we want to happen. Because for all my behavioral scientists in the audience, not doing something is not a great behavioral goal because it's not specific enough. Not doing one thing, there's still lots of other things you could do, which is why we flip from problem to solution or program objective positive, so that we can therefore say, okay, we know exactly what we want people to do. And so then we can start to build a program around that. And again, all of this is completely evidence-based. We then move on to step 3, which is where we start to have a lot of creative fun because we get to start to design the program. And so this is a lot more involved than a traditional behavioral design program or even a normal app design program, which Bree will talk about later. But this also starts with evidence because once we've identified in steps 1 and 2 the knowledge, attitudes, skills, and beliefs that need to change for each player in this ecosystem, for each larger behavior that they contribute to, there's then a whole lot of research and literature review that's available for, okay, what's the best tool to use to change knowledge, attitudes, skills, beliefs for this behavior, for this type of target audience, for example, doctors. So that's where we do another round of literature review to find the most appropriate evidence-based behavioral science tools for each of the bottom things in that pyramid that need to change to then flow up to that big behavior change to contribute to improving that health problem. So it starts with that, and we say, okay, we've narrowed down the range of possible behavioral science tools to something that's relevant and effective for what we're trying to change. Now we're going to have a brainstorm. So then we had a really fun brainstorm with the Wonderman Thompson team, the apps team, and ourselves within the bounds of what we'd identified as effective tools to say, okay, here's our range of options based on the evidence with our behavioral goals in mind, again, based on the evidence earlier on. What could this solution look like? We didn't say we're going to make an app. We said, what is the best solution to deliver these behavioral science tools for this target audience for this problem? And we had a lot of brainstorming, which led us eventually to decide to make an app because that was the best way to deliver the tools that we needed to deliver based on the problems we wanted to tackle. And that was a lot of fun and a lot of creative discussion and back and forth. As part of that as well, we also made sure that we got input from our target audience, which was HCPs, healthcare providers. We decided to focus on the interpersonal level of that onion of the social ecological model based on where we sit as organizations, what we can influence, and where the evidence showed us is most effective to intervene. And it was kind of a feasibility impact balance that we made there for this pilot study. So based on that, once we had kind of brainstormed the ideas in that creative session in step 3, we then made sure that we got the input of healthcare providers who are residents. So in the US medical program, a resident is a doctor who has finished medical school and is on the job training for a number of years, but is not a full-fledged doctor yet. And so this is a great time to start to intervene because your habits as a doctor are not yet totally set. So they're still learning, they're still relatively young doctors. So this was where we identified as being effective. So Bree and the Wonderman Thompson Health for Equity team organized an advisory board of resident OBGYNs who would be able to provide input on what would be the most effective tools, effective delivery, etc., on top of the evidence base that we'd already used to narrow down our options. And Bree can tell you more about what that process was like. And then from there, we started to go into program production. So I will stop there and I'll hand off to Bree to add to any of that and or go straight into.
Great. Yes. Yes. Well, I'd love to add that what is incredibly important to us and part of the ethos of Health for Equity in co-creating and designing for the audience with whom we intend to serve. It was incredibly important to us that the cohort of physicians who advise us are Black women. And so the OB resident physicians whom Suzanne is referring to are a group of Black women. And as Suzanne was noting, we find that this point of care, which not only addresses the intention for us to address that layer of the socio-ecological model onion that Suzanne shared, but also, as Suzanne was indicating, this critical time for which not only are these residents in their training, but they also have the incredible opportunity to influence the next generation of OB practice. And not only that, but in a sense, share with their attendings and for those who are training them, experiences that they have as Black women in their training and with their Black patients, and those things that they experience that are critical to be integrated into point of care interactions in order to address the inequities that we are seeing in Black maternal health. So that has been incredibly important to us to work with this phenomenal group of physicians. And so, as Suzanne said, we started by having a focus group to ensure that the features and the focus of the app would actually service what is most critical and most needed for them to use in their interaction and in their service of patients who have these unmet needs that contribute to inequities in Black maternal health. So with that, with their insights and with those inputs, we then collaborated as part of the next step of program production with the Wonderman Thompson Apps team, which is a sister agency within our WPP Wonderman Thompson network. And we can actually go to the next slide that I can start to talk through. And we acknowledge that you cannot see too much here. That is a bit by design, as this is not released yet. So we look forward to sharing with you all when the pilot does officially arrive. But what happens next after we gather these critical insights is we have been developing these wireframes. So the Wonderman Thompson Apps team takes the insights and the intention and strategic direction of the app and develops a user-friendly experience with these wireframes to display how a physician and their patient would utilize this app in service of addressing some of the inequities that we are hoping to address. So where we have landed directionally with the app, and then we look forward to sharing with you more when it does get launched, is that we are actually focusing on the space of resource connection and allowing greater feasibility and access to resources that might address some of the unmet needs of what Black moms might experience during their OB care. So this shows some of the journey that we are working through with the UX design team. And what happens next is continued work with the developers on the back end, continued work with our creative team at Health for Equity on integrating some design to add to the user experience. And then from there comes the next steps where we look to implement and pilot. And what we have been really excited about is, again, this aspect of co-creation and our ethos of by us for us, that really we want to be able to serve the community we are working with. So our pilot study will be with this cohort of physicians who are consulting us. We will start with one pilot area before we expand, hopefully, to others. And with that, there's also the critical aspect of us integrating KPIs and measurement tools to be able to continually analyze and optimize how the app is functioning, how we can continue to optimize further versions of the app. Suzanne, I don't know if you want to add to that from your perspective in terms of how we will continue to look at that from a behavioral science perspective.
Absolutely. So, this is a pilot and this is also behavioral science. And so both of those things require testing and measuring and iterating to be done completely and to be done well. So one of the next things that we're doing in parallel with the Wonderman Thompson apps team, as they're continuing to develop the actual app itself, is the KPIs and the metrics that we're going to prioritize in this pilot program. And what we're looking at is not just the usual things that an app would look at, like downloads or logins or what's being clicked on, but we're also going to look at it from the perspective of all of that literature review that we created as the foundation of this process in intervention mapping in those first few steps that I showed you earlier. And the nice thing about, it sounds like a lot of upfront work when we do those first few steps of lit review, and it is, but then we can go back to that continuously and say, okay, it's all here for us. We know that this tiny knowledge thing, this tiny attitude thing, etc., are all laid out as important, and we built the app on them. And so we go straight back to that knowledge or that attitude and that belief and say, well, how do we measure this? What's a validated measure? What's the best measure in this target audience? And that's where we start to pull the metrics from. And so that's what we're going through right now, is saying, okay, in addition to the traditional app measurement metrics, what are the behavioral science and evidence-based metrics that are going to be most relevant to the desired behaviors and that we're trying to drive with this app based on all of this strong foundation that we've laid with this academic research that we've been doing up until this point. So that's a conversation that's happening right now as we're finalizing the design of the app. So hopefully next year we'll be able to share with you not only exactly what those metrics are, but also how it went, because we will have piloted by then, which is super exciting.
Great.
So I'll hand it back to Bree to talk about from their perspective how this has been.
Yeah, thanks, Suzanne. Where I'd love to go, with this slide is a moment to talk about why is behavioral science approach different? Why was it so important for us as Health for Equity to partner with BVA Nudge Consulting on this effort? Suzanne spoke about this earlier, that the unique approach involves focusing on the behavior first and then the solution. If any of my agency colleagues are watching, we know there is never a lack of compelling creative, incredible solutions that we design in the communications and marketing space. I think what is unique and special about partnering with a behavioral science group is that we are able to really focus then on the interventions or program designs that really are most likely to affect change in the real world. And some of these other notes here bring about why that's possible. It's because we break down behaviors into very specific sub-objectives that allow us to ensure that we are addressing these objectives as we go through the design process. It also allows us to think about our solutions as they are integrated into the whole sphere of the socio-ecological model that Suzanne presented. Of course, I am very admittedly biased because I too come from a public health background. So I think for me, this has been especially exciting to pair my passions of storytelling and creativity that, you know, are expressed in the marketing and communications world with, as Suzanne has brought throughout this presentation, the rigor and scientific evidence approach that comes with this programmatic design. And as this final bullet shares, that we are able to ensure that what output we come up with is entirely evidence and theory-based. And not only that, backed by behavioral science principles that we know, human behavior and mindset is extremely challenging to address. And as a marketing strategist, we discuss that all the time. What's compelling to me is knowing that there are scientific principles that can help lead us in a direction to a more confident approach to designing these tools, to ensure that those things that we do develop are more likely to be adopted. And not only that, I think something that we observe, maybe not only in the marketing space, surely in the public health space as well, is that oftentimes an amazing solution with all the best intentions gets launched into the world, and perhaps what gets lost is sustainability. And so with this approach, we're hoping to design interventions that can not only make a mark when they're first launched, but actually be sustainable and carried through and continue to iterate and continue to be optimized to serve the objectives that we set out to address inequities in Black maternal health. So I hope you can feel from my passion, the excitement of why it has been so critical and exciting for us to partner with a group like BVA Nudge Consulting to really add this rigor to our strategic and creative approach. And with that, actually, we did already discuss some of the program implementation and evaluation that we are embarking on. And so with that, I think we can probably close the presentation part of our discussion, unless, Suzanne, you had additional to add.
No, I think you nailed it. We've discussed, we're at the point where we are mid wireframe and mid KPI design, and then we're going to launch it with the help of our amazing physician advisory board. And we're really excited to get this out into the world and start to see the impact that it can make. So thank you, Bree, for your and the team's awesome partnership on this and for sharing this with our Human Advantage Conference attendees. I know we're all really, really excited about this.
Thank you all so much.
So thank you so much for sharing all of this. And you cover a lot of my question, but we are not in live, so we don't have an audience, but I have few questions and we have a bit, more time. So what challenge did you face in developing and implementing the app, and how did you overcome them?
Bree, do you want to go first or shall I?
Sure. Mostly I will say it has been a beautiful, positive synergy with all of the groups involved. I will say, an interesting strategic challenge that we encountered and a question that we ask ourselves as marketing strategists always is, how do we come up with a solution, in this case, an intervention that is not only culturally competent, meaningful, addressing Black maternal health inequities, but is also unique and differentiated from what is already in the ecosystem of what is available. At Health for Equity, we enter the health equity space with humility, knowing that there are many, many grassroots efforts. And in fact, we spend a lot of our time seeking those partnerships, looking for those consultations with those who are already on the ground doing incredible work in Black maternal health. So it's important for us to bring something to this space that is addressing unmet needs and will truly be something that is useful to those who decide they would like to use it. And so I think in our brainstorms where we were narrowing down to various options, one felt like it was meaningful and useful and important, but perhaps already existed or had been done before. And we felt very passionately about going in a direction that was admittedly, it is slightly harder to execute in what we have chosen. However, we feel that when we come to the realization of the app and when it is finally brought to life, that it will affect meaningful change and in fact be something that's differentiated and can contribute to an unmet need that does exist, while honoring those interventions and tools that perhaps already exist in the space of Black maternal health inequities.
Thank you, Bree. Suzanne, you have something to add?
Just briefly, I agree with Bree completely that this has been honestly a real fantastic project and a dream to work on. I'd say from my perspective, the biggest challenge has been just keeping this pilot-sized. MVP, minimum viable product. I say that a lot in our meetings, and I put my mean hat on and say, is this pilot-sized? Because, this is such a really massive, complicated problem, and we all have so much passion and heart for wanting to do as much as we can to tackle it. And so the feasibility of we need to start somewhere practical, somewhere that we know we can get really strong metrics from to build momentum, the evidence base for this approach in this space by this team, and then build upon that. So it's really been a fun problem to have so many really amazing ideas and so much enthusiasm and energy, and just needing to pick a direction to start with. There's lots more to come.
Okay. So we have a few minutes, so we will talk, if you're okay, of your vision of the contribution of behavioral science in the field of health and the care pathway and the patient experience. So I have a few questions on this subject. So how do you see technology and behavioral science continuing to intersect in the field, in the healthcare field, particularly when it's come to improving health equity for minorities, marginalized populations?
Sure. I find this question to be very inspiring, and actually it reminds me of, I'm going to quote a dear partner and now friend, and actually, again, credit to Suzanne as, part of our partnership over the past few years. Suzanne has introduced us to some incredible other partners who we work with, one of them being the Good Listening Project. And one of the poets who we work with, Her name is Dr. Yvette Perry. We were in another setting earlier this year, and she said something that has resonated with me so much that I continue to quote her time and time again. What Dr. Perry said is that our most potent technology is actually our humanity, and that's what we need more of. And where I see this being relevant to this conversation is I find behavioral science to be a major connective tissue in that. What we love to do at Health for Equity in working with community grassroots efforts to address inequities and understanding that there is technology, we have tools, we have AI, we have apps, but behind that is humans and humanity. And we, at the heart of everything, in order to affect real change, we need to get to mindset and behavior change. And so I find that working with a group of experts in this field is so beautiful and meaningful, because it really is that connective tissue from tech to humanity. And that is why it is so critical that we consider behavioral science in all that we do.
Suzanne, you want to add something?
No, I think Bree nailed it. Technology is the tool. I know everyone's very excited about AI. Every conference I go to, most of the talks are about AI, and absolutely it's the future, but it's the delivery mechanism for an intervention. It's not the intervention itself. So the intervention itself still needs to come from an understanding of how people work, how to change their behavior, and then it can be delivered through AI, through an app, through a poster, through a mailer, whatever it is. But that's why this intervention mapping approach has been very helpful, because again, it starts with what is the human factor that needs to change? What's the best way to change those human factors? And then we come up with the way to deliver that. So I think absolutely it's just another great delivery mechanism, but it's not an answer in and of itself. You need both.
Thank you. And last question, what advice would you give to other researchers or practitioners looking to use behavioral science principle to develop interventions to address health disparities?
Be humble.
Go on.
Know what you know what you don't know. It was very serendipitous to meet Suzanne in the way we did in a context of a larger strategy group meeting. And I think seeking those partnerships to address areas that we might not be as experienced in is critical. Whether you come from more of that marketing strategy perspective like me, or even from the behavioral science side, I think so much more is achieved when we have diversity of thought and collaboration. And so I think that would be my greatest advice is enter into the conversation humbly and with an openness and willingness to reach out for these partnerships and collaborations.
Thank you.
So good. Not much to add to that, Brie. Honestly, it is about the people that's involved. The tools are obviously important, but also having the right team and making sure that, as we've mentioned, you involve not just diversity of thought from a marketing or behavioral science perspective, but also your target audience, which is why this physician advisory board has been so valuable, and will continue to be so for so many reasons. So that adds to the humility of saying, yes, we can know all the science, know all the science as much as one can, et cetera. But it really is, it's not our lived experience. And so making sure that is always brought in is really critical as well.
Thank you so much. It was really interesting. Thank you for sharing all of this. So this is the end. What would be the final word to sum up this discussion, or to something to say to the audience?
Gratitude. Thank you so much to the Human Advantage Conference and community. Thank you to Suzanne and your incredible team for working with us the past few years. Thank you to our incredible community of grassroots collaborators and our consultants. As Suzanne said, it's absolutely so critical that we are co-creating these solutions with the audience who has experienced these inequities themselves. And so I now sound incredibly repetitive, but I just think it all comes down to these partnerships and collaborations. And so if I were to sum up with one word, I would say gratitude for being able to have these opportunities to connect and meet others who are so passionate about this field and are in the spirit of collaborating together to affect real change.
Thank you, Bree.
And I would come down to bravery and patience, and gratitude for both of those. Really grateful for Bree, you and the whole team's willingness to try something so new and so big as a first time partnering together. This has really been amazing to see your openness and a passion for this. And I'm really excited where it's taking us all. And with that comes the patience, which is anytime you're doing anything new, anytime we're doing anything with lots of collaborators, everything's gonna, things are gonna happen that take longer than expected, and humans are gonna human. And just knowing that that's okay and that's part of the process and bearing with it all has been really, really awesome. So thank you for being a really strong partner with us and with all of our other great stakeholders on this journey.
Thank you so much.
Thank you, Marie. Appreciate it. Thank you
Thank
so
you.
much. Take care.